Alright, hello everybody, my name is Eric Walls and I will be presenting on normal pressure hydrocephalus today. So, a few interesting facts. It's actually not that common, 1 to 1.6% of the population gets it, but it is much more prevalent in extended care facilities such as SNFs. So watch out on your clinicals coming up here. It's also misdiagnosed a lot as dementia, so there's actually 375 misdiagnosed cases with dementia. And then the normal pressure part of the name is actually given to it because of the lumbar puncture pressures that they don't really change with this diagnosis. Alright, so a little bit about the etiology. There's two types, idiopathic and secondary. Idiopathic is much more common, and that's where you're going to get enlargement of the ventricular volume and then increased ventricular size, which causes compression on the brain. And then that compression on the brain is going to lead to a triad of symptoms, which includes urinary incontinence, gait deviations, and dementia. And then the secondary form is only a third of the presentations, and it's usually due to disease processes such as meningitis, head injury, subarachnoid hemorrhage, and encephalitis. So, going into the signs and symptoms, wet, wild, and wobbly. You got urinary incontinence, dementia, and gait disturbances. And once again, these are all created due to that increased pressure in the brain, pushing on the different areas of the brain that control each of these three. With NPH, the base of support is usually wide, and the Parkinson's base of support is narrow. This is important to note just because Parkinson's usually presents pretty similarly to NPH. A little bit about the pathophysiology. The exact pathophysiology is unclear, of course, but cerebrospinal fluid dynamics are affected by production and absorption. We know that. So then in this disease, researchers also know that it is the absorption that's affected and not the production of the CSF. Alright, so a little bit about the normal CSF dynamic. The CSF is formed by the choroid plexus within the ventricles at a rate of 20 to 25 milliliters per hour. It then circulates from the lateral ventricles to the third, then to the fourth. And then once it gets into the fourth, it's going to exit that ventricular system and go into the subarachnoid space around the brain and the spinal cord. At the end, it's finally absorbed into the arachnoid villi. And that's kind of where the problem occurs with normal pressure hydrocephalus. Here's just a picture of what I just told you. So it starts here in the lateral, goes around to the third, then down to the fourth, and then spreads out in the subarachnoid spaces. Alright, continuing on with pathophysiology. So we know that the arachnoid villi cannot maintain the adequate removal. Some of the theories for this are fibrosis and scarring that impair the reabsorption of the CSF. Also cerebral vasculature that may have a role in the pathogenesis. Slow progressive impairment of the periventricular blood flow, and injury to the neurotransmitter and neuropeptide systems. This is a good picture of a normal brain compared to a normal pressure hydrocephalus brain. As you can see, the ventricles are just huge on the normal pressure hydrocephalus brain, whereas the normal brain much smaller.